Alexios will ask the questions. First, Henning will present about
I will do the presentation. I have a 10 minutes PowerPoint.
Perfect.
Video and so on.
After that, we have prepared around 6 to 8 questions because, you know, we have limited time.
Yeah.
And we will arrange according to it. You are free to speak, both of you. If you can also transfer to answer to other. Yeah. Also, you know, this is a new. It's the first time we will live broadcast this event to the Twitter. Oh. So I will look at the Twitter feeds. Some people may join and ask something. If possible, I will tell you. Maybe we have interesting questions or interesting session. Also, we have more than 100 registrants to this webinar. We don't know how many of them will join tonight.
Okay, we will see.
Actually, we have 16 people join it. They will ask their question by writing on a Q&A box, and you can also experience it in the FAPS course, so you can answer you are liberally talk anything.
Okay.
So the questions, I will be asking the questions that we prepared. The questions from the audience, will you be transferring them to me, or will you be transferring them directly?
Alexios, you asked the questions from our presentation, you know, the 8 questions.
Okay.
And at the end, I will, if I find opportunity or any question from the audience, I will share it at the end of the session probably. But we have 1 hour, we have limited time, this session.
1 hour?
Last 1 hour.
1 hour, that's great. Okay, so should I upload my presentation?
No, you can, you have opportunity to share your screen when we started.
When it started?
Yeah.
Okay. Then
we have, I guess, 3 minutes to start.
3 minutes to start, and after start you make
I will make a short presentation and we will give you.
Okay,
and then you will do all the questions, or should we do first the first 6 and then look for questions from the chat or for Twitter?
Repeat again.
Should we go through with all the questions that we prepared, or should we just do the first 4 or 5 and then look for interesting questions from Twitter and from the chat? And go back to the rest of the questions if we have more time.
Yeah, actually, we should ask our first 4 or 5 questions.
Yeah,
and I will check the Twitter synchronously, and if I see interesting, I will tell you.
Okay. Very nice.
Wonderful.
2 minutes to start. Yeah. Yeah, the kids.
So it's fine. I'm opening the session.
Okay.
Good evening, everyone. As you know, the European Hernia Society has been organizing a journey club monthly on Twitter since October 2020, excuse me. We have made 9 activities so far. Now we are doing the 10th live for the first time. This month's article is about a new technique in the treatment of complex abdominal wall hernias. The title of the article is Intraoperative Fascia Tension as an Alternative to Component Separation, a prospective observational study. 2 esteemed authors of this multi-center study are with us, Henning Niebuhr and Wolfgang Reinpold. Thank you both for joining us.
Thanks a lot.
They are both working on abdominal wall surgery in Hamburg. They hosted the 41st Annual Congress of the European Hernia Society in Hamburg in 2019. It was a great success indeed. Wolfgang is also a board member of the European Hernia Society. This live meeting is scheduled to last 1 hour. First, Henning will make a presentation about the article, and then we will ask the questions. Yeah. My co-chair, Alexios Theodorou, is social media wing member of the EHS and works as a general surgeon at the University of Bonn. This meeting will also be broadcasted live on our Twitter account. We will also share the questions and contributions from there. Yes, Alexios, I will hand over the talk to you.
Okay, so good day, everybody, or good evening, if you are somewhere where it's evening. Thank you for joining for the first live journal club of the European Hernia Society. And thank you, Hakan, for organizing this, and of course, Wolfgang and Henning for joining us for this, for discussing this very interesting paper that you brought out about this technique. So I will share my screen with the questions that we prepared. Hakan, you have to allow me to share my screen. I don't have the...
Oh, I will...
But perhaps we should first allow Henning to present the paper.
So I will do. So I will share my screen. And... Okay. Does everybody hear me? Hello. Good evening from Hamburg. Fine that I am allowed to speak here and bring the information about the experience of vertical fascia traction for W3 hernias, EHS. And we released this article in Frontiers of Surgery, and we have a new one already in the pipeline for Der Chirurg with some new and more other results, which I will present right here. Incisional hernia, frequent leg complication in abdominal surgery. Incidence rate is about 20% 1 year after laparotomy. Large incisional hernias are a challenge for abdominal wall surgeons. Patients are older and more obese. Hernia sizes between 10 to 25 centimeter in transverse extents and up to 30 longitudinally are not uncommon. Due to lateralization and shrinkage, not only of the rectus abdominis muscles, but also of the 3 oblique muscles, the hernia becomes increasingly larger and can ultimately no longer be closed without tension. That's a problem. In this extreme form of incisional hernia without surgical reconstruction of the abdominal wall, considerable complication can occur, some of which are life-threatening. Eucker from Germany or from Switzerland describes an innovative procedure for the treatment of large abdominal wall hernias. He calls it for the AVEX, abdominal wall expander. Vertical fascia tension is administered to the fascias, and so a direct facial closure is possible. Eichelter did an in vivo porcine model, and he could demonstrate the effectiveness of abdominal wall tension. Based on these results, we thought that it's a good idea to applicate it in large incisional hernias, more than 10 centimeter transverse diameter, W3, according to the EHS. Fascia traction, the hypothesis of our upcoming RCT, which we are in preparation, is the method is a reasonable alternative to the previous technique with component separation for treatment of large abdominal wall hernias. Fascia traction can in particular help avoid the risk inherent of component separations. Component separation gains a rate of wound complication up to 48.2%, Ramirez. Ischema, seroma, and wound infection are very often as complications after those component separations. Sorry for that. The technique of fascia traction is simple. We got to deal with an external device. We have a carrier, we have a frame, we have a spring balance, and we can perform a vertical or diagonally or even mixed fascia stretching intraoperatively. Primary, we can gain a tension-free abdominal wall closure, and it helps to avoid a component separation or a dissection. For the technique, it's important to prepare the hernia sac Do an adhesiolisis as far as necessary, otherwise leave the second tech and leave it, don't cut it away. Limit epifascial dissection of the rectus sheath to 2 to 3 centimeter because of circulation. Incision of the posterior layer, according to the Milos procedure of rectus sheath, gains or allows the sublayer augmentation. Then for getting these, the traction in position, you need U-hole sutures, bicryl 1, in the anterior layer of rectus sheath longitudinally and 1 centimeter lateral to the fascia edge with a 2 centimeter stitch length. Insertion of the mesh in sublayer position before you start with your traction, and insert also the radon drainage from the mesh bed already prior to the traction. Technique number 2, you need to lock the holding sutures in the frame. It's a special frame, you would see a picture of that. And then you can individually retension the single sutures, and you perform a 30 minutes controlled defined tension on the fascia with 10 to 12 kilo. And you have a vertical or a vertical diagonal traction. We prefer the diagonal vertical traction. Intraoperative measurement of fascia distances under maximal relaxation. It is very important to have a good relationship to your anesthesiologist to gain a really maximum relaxation of the patient, because then the results are even better. Intra-abdominal pressure has to be measured continuously, indirectly, and intravesical. And here you can see on the right side, this is the technique with the carrier and with the frame. And here the sutures are clamped into the frame. And here you have the controlled kilograms and so on. This was a patient after different laparotomies, after perforatus, appendicitis, and peritonitis. Multiple laparotomies were performed with VAC treatment, and there was a big incisional hernia, as you can see here. We performed at that time the procedure with the fascial tense intensive care. This is made for open abdomina, for treatment, for longer treatment, day-long, week-long treatment of intensive care patients, with a system to avoid the development of a big hernia. And here you can see the hernia model with the carrier here and with the frame. And here you can see under traction, it's a little bit boring for the surgeon and he has to wait for it. You can also perform the traction not only in the open wound, but also transcutaneously. This is also a little bit combination with the Milos principles, so that you can avoid to perform a really big incision, and you can do it subcutaneously, and yet you can see here transcutaneously you can perform the traction as well. And this was pre-operatively, and this was post-operatively. I think it's it's a fine result. Okay. Here you can see the progress of gain of facial length intraoperatively. This is distance of fascia at the start of the treatment. As you can see here, it's a really big distance of about, let me say about 12 to 14 centimeters. Distance after 10 minutes in a longitudinal dissection, it is much more less. And here, after 50 minutes and after 25 minutes, it's nearly closed. And here you can imagine that it is very simple to perform a suture of the anterior layers of the rectus sheath. Here, once again, another case. This was a big case also, really big hernia, W3. You see in the CT scan that there is a scar bone inside. And this was a scar bone which we resected totally here from this abdominal wall. And you can imagine that you do not have enough structures to make a really good closure. The anterior sheath of the rectus muscles were not completely intact. So here we had to do, after the resection of the scar bone, we had done also the traction here, also transcutaneously. And we didn't reach enough length to close it correctly. So we had to perform, first of all, a TAR, transverse abdominal release. We did it. And we performed an open IPOM because the transversal fascia was not intact any longer after the TAR, because it was very complicated to perform it because of scars. And then we had to underlay it with an open IPOM mesh, sewed it into the transversal fascia, performed our sublay mesh, and then we did a bridging inlay, sewed in also. And here we had a procedure time of 4.20, and we had a good results afterwards. But I want to say, the fascial traction is not the only thing, only technique to perform all the, or to cure all the big hernias, but it is a step, it is a tool in the toolbox for the abdominal wall surgeon. And you see, in some cases, it's necessary to combine it with a TAR and with any form of a component separation. So it is not the only one, but it is in combination a very good tool to do it. And in a very high number of cases, you can avoid to perform the component separation. Here I show the technique in a short video. You can see I'm opening the posterior layers of the rectus sheath, and under my finger here we have the anterior sheath of the rectus sheath, of the rectus muscle sheath. And here you can see how I insert the holding sutures 1 centimeter from the edge of the anterior rectus sheath. And here you can already move the abdominal wall, and here you can see how we are fixing it in the frame. And now the power is done, and you can see how it works, and we can retension it with those little clamps here. And now after the traction period, we can simply close the fascia. So these are a little bit other numbers than that in the Frontiers article, because this is after 50 patients, results after 50 patients, and it just increased a little bit the number of the centimeter of the median hernia width to 16.2. And we had a highly significant gain in fascial length of 10.2. In the last publication in Frontiers, it was 9.8, but there is no big difference, of course not. Low tension closure was possible in 45 of 50 cases after traction. 5 cases were requested to perform an additional TAR and bridging with up to 44 centimeters. We had no post-operative abdominal compartment, and we had a pain VAS of 2.5. This is okay, post-operative pain. Up to now, gain in fascial length is only possible with different forms of CS, Ramirez, endoscopically assisted component separation, and transversal abdominal release, open or laparoscopically or endoscopically. Due to the invasiveness of these procedures, complications are more frequent: seroma, infections, hematomas, abdominal wall necrosis, sensory disturbances. The fascia traction, as summary, enables primary closure of complex hernias in a lot of cases, not in all. It may be less prone to complication than the methods of component separation. You can see further treatment options found in Merano. Thanks for the attention. Hernia removal, T, wonderful. Thank you for the attention.
Thank you very much for the presentation. I think it is a very good beginning to start with our questions. So I will start with the presentation we have prepared with the questions. Okay, so this is the paper that was in the Frontiers in Surgery in February. And so how is fascial tension facilitating the fascial closure? What is the advantage there that allows this to happen?
Okay, the advantage of the technique, it is really simple technique. You do not have to perform the component separation with separation of the fascias of the different muscles of the 3 obliques. And by avoiding that, I do not have anything against it. I perform it on my own very often as well. But I think if you leave the lateral abdominal wall intact and you do this while you are doing the traction, it is advantage for the patient because we do not know what is happening with the component separated patients after years. Do they have a bulging? Do they have any less power and force in their abdominal wall? We do not know that. And by that, if the fascia traction is successful, then it is of advantage to perform that. It's easier and it is less prone to any complication in the lateral abdominal wall. And I have to add that we perform always a Botox preparation of the patients in the lateral abdominal wall 4 weeks prior to the operation. So you have a combined result and a combined success. And you cannot say, well, whether it's only the Botox which makes this possible, or whether it's only the facial traction. I think it's both. It's just the same. A lot of people doing the component separation also after preparing with Botox, and they have the same problem, if you will say so. Okay.
Yeah, so that also covers another question that we had about the Botox use in this technique. But like you said, you use also component separation techniques that have become very useful in the latest years among complex abdominal wall hernias. But in which patients will you use this technique instead of a Ramirez or a TAR?
I will try, first of all, when I have to deal with a W3 hernia, more than 10 centimeter in the width. Then I start in longitudinal incision, longitudinal hernias, midline hernias. Then I perform the fascia traction as first method of choice. If I see that I cannot gain enough length of the fascias to close it completely or comfortably, then I add the TAR, the transverse abdominal release, as a second method. And if I do not reach enough length, then I perform the bridging mesh.
Okay. And would you use it also only in central ventral hernias, or would you only use it in lateral, like
Yes.
after a nephrectomy or a lateral hernia?
It is possible to do so, but it is not so easy. It is the best way to perform the traction is in medial hernias, of course. That's right. They are best for using the traction method. And if you have lateral hernias, you are very often, it is very often necessary for you to perform any kind of component separation because of scars and so on, and you have to reach any kind of layer where you can put on your mesh in sublet position. So this is not always very easy to perform the traction. We try it as well, but the best ones are the midlines, of course.
Okay. Do you foresee any negative effects of the strong tension that you do to the tissue due to micro tears on the tissue because of the short amount of time that the traction, the tension is used, and that will probably cause some consecutive inflammatory response?
Yeah. Well, this is not researched consequently right now. This is clear because time is too short. We are practicing this method. But in the posing model, which I have talked about that was an Eucker, but I don't know what was the name of him. Okay. In this posing model, we didn't see any effect of those which you have mentioned here. But this will need further research, of course.
And okay, I think we discussed already about this question about Botox.
I'm sure about that. It is really important to do that.
And another is the length increase after the application seems to be very variable. How can you explain this? What is your explanation of this?
Yeah. If you have in the upper abdominal wall, if you have big defects there and want to perform the traction, it is a little bit worse, not so effective as in the lower or mid abdominal wall. I think this is explained by the construction of the abdominal wall. If you see to the lateral muscles, they are fixed in the bones, more to the ribs, and in the mid of the abdominal wall, they have smooth positions of the lateral muscles. So you can gain more in the midst of the abdominal wall than in the upper part of the abdominal wall. And if you're coming down to the bladder, or if you're coming down to the lower parts of the abdominal wall, it is also much easier than in the upper parts. And by that, you have these differences and the wide range of the fascia length, which you can gain. And on an average, we are up to 10 to 2 right now.
Okay, but I think this is similar also to the increase you have after performing ATAR on the upper third in comparing to the under.
It's pretty similar, I presume, as well.
Yeah. Have you tried to use Botox on the upper muscles? Because usually when we use Botox, we do it on the lateral, that more affect the down quadrants of the muscle. The upper quadrants are not that affected by the Botox.
That's right.
So that could be some possible use there.
Well, we have a protocol after that we perform the Botox ultrasound control, the Botox installation. And so we do it always in the same positions in the laterals and in 3 points every side. And so we have a standard for that. And I cannot answer that question really completely.
Yeah, so let's say it's promising results indeed. What will you say about the future of this technique?
Well, I think this is not the end of the technique. We have started to mix it up with the knee loss principles, so that we keep the skin incision small as much as possible. It's clear, so we can reach all the hernias. But we can imagine that this procedure is also keen to perform it in combination with the knee loss procedure when you go transhernally, and can perform your space making under the rectus muscle. Then you can perform it transcutaneously as well. And we are just thinking about how to perform this technique and doing the next, I think after 14 days, we will have a patient to perform that. And we want to try that. And I think this is a big step ahead for the future of this technique. And Peter Berger from Zurich, I think he is in Zurich, I don't know, example, or in Basel. He performed a complete laparoscopic approach with the fascia tension, and he used this for rectus diastasis and a very small hernia and rectus diastasis, and it worked also. This is not the end point of the technique. I think we have a good future, a bright future for that technique as well.
Okay, very nice. There are some questions from the chat as well. For example, about the use of this technique in large incisional hernias with stomata. Do you think that you can use this in patients that have a lateral stoma?
You mean the stoma hernia?
No, if a patient has a stoma.
You mean abdominal wall stoma?
Exactly, and she also has a hernia. So if you can use this to treat patients like that.
It's, if it's a lateral hernia or if it's a medial, you can use it in lateral and in medials as well. But I think for the medial, it's even better. The results are better, of course. And the other question is if you have an open abdomen on the intensive care. This technique is used with the tripod, which I've shown in between in my cases. Prior to having how is it called? We used this tripod where the tripod is standing on the patient. This is made for intensive care patients which have an open abdomen to avoid the development of a hernia and to avoid that the fascias are retracting very much and becoming very hard and very hard to perform the closure after that. And that's a very good idea to do as well. And therefore, we have another system. This is called for open abdomen, while our system is called for hernia. But it's
I can, if I can do a comment about the open abdomen, we use this system for open abdomen in Bonn as part of the initial study as well, and we use it to as affiliate abdomen closure, and we use it with a mesh, and we have good results.
Actually, can I say something?
Yes, please.
Actually, in our previous journal club, our paper was related to the open abdomen with fascia tense, this device, and we discussed it. It works in the open abdomen as well as, and also, you cannot use Botox in open abdomen because in a short period you should try to close the abdomen in it's about 10 to 12 days. But Botox, works in 1 month.
Right.
So if you compare to the hernia with the Botox, Botox helps, but actually we need more studies. How much Botox help this situation with fascia tense?
Yeah, that's right.
Wolfgang, what would you like to say about it?
Yes, I think it's a very interesting and a very good technique. Henning made a great presentation. He has by far the most experience with it. I have used it several times, also with good results. Our technique in the real large W3 incisional hernias is always start the operation in the less open Milos reef stopper way of the operations. So we enter the rectus compartment. We do the dissection between the posterior rectus sheath and the rectus abdominis muscle, and in the end we see whether it is possible to close the gap, the hernia defect, with low tension. And if this is not possible, our standard procedure has always been in the last years the TAR procedure, mostly in the Milos or E-Milos technique. However, sometimes if you can't close the gap, now we consider using first, before doing the TAR procedure, the fascia tense maneuver. It costs you about 30 minutes, and it gives you several centimeters on every side. Henning has published, or we have published our patients with a release of about 5 centimeters on every side, which is considered a good amount of release. However, Henning mentioned it already. In the upper part of the abdomen, in the epigastrium, where we have the bony margins of the epigastrium of the rib cage, of course, the release is not so good. We have also tried to use the fascia tense maneuver with good results in these patients. And if at the end, after doing the reef stopper dissection of the rectus compartment, after fascia tense, and after TAR, if after all these 3 maneuvers it's not possible to close the gap completely, then we do the bridging, and we do it. We insert a very large piece of mesh in the retrorectus space, in the laterally in the preperitoneal space, overlap of at least 10 centimeters circumferentially, and then we put a second piece of mesh in the same layer, and this second mesh is attached to the margin of the hernia defect. Why do we use a second mesh? Because we priorly we had a severe complication in patients where we stitched the fascial defect to the large mesh, and it led to a mesh rupture. So if you use a second mesh, you can safely attach it to the fascial margin and close to the hernia defect with a little bit of bridging. This is our policy, what we do right now. Henning has mentioned already combining it with a Milos or E-Milos approach definitely is, in my opinion, a very good option for the future. We need more data about this. I think we can use this technique in all large hernia defects of the midline, of the lateral compartment, or after transverse large hernia defects after transverse incisions. Even in parastomal hernias, I think it's possible to use the traction for approximation of the abdominal wall and making the hernia defect smaller. So I think it's a very good new tool if it comes to the treatment of large and giant ventral incisional hernias.
Very nice. A question from the panel and from our president about the predictability of the elasticity of the abdominal wall. Is it helpful? Are there any tests to help plan this pre-operative to see how elastic is the abdominal wall and if it will give away?
Yes, you could perform this via elastography and ultrasound, but this is in the kid's shoes. It is very in the beginning, this process to try to do that pre-operatively. We did it intraoperatively to obtain an opinion how much it gains in facial length, that we started to measure the power which is necessary to perform a closure of the fascias with the hands, only with traction of the hands. Then we try to find out how much it is. And once we tried it also to define it after kilograms, which you have to pull on the fascia to gain the same result. But this is also in the beginning of the method, and this was intraoperatively. So pre-operatively, to get results which can say anything about the elasticity of the muscles, I think this is hard to get. I don't know how we should do it, probably the elastography and ultrasound.
Another question, it's about, you're using the fascia tense device. Eucker, as he first described this abdominal wall system, expansion system, used standard retractor, like an OmniTrack. Yes. Is it possible to use this instead of the fascia tense? And what is the positive effect? What is the big advantage of using the fascia tense?
Okay, you can use it. You can use the technique of Eucker. He did it, and he showed that it works. But you do not have a controlled traction, and in facial tense you have a controlled traction, and you can perform a little bit more effective fixation with the U-hold sutures. Eucker, he used clamps to do it, and he used drains to connect the clamps with the frame. And this works, but you do not have any control how much force you are putting on the muscles and on the fascia. On the fascia, the traction comes to the fascia, and so by that, I think this is really advantage. It is a more refined system, and you have a good control of the power you use to tract on the fascias. That's it.
Does the payer system here in Germany cover the extra expense of the device? Were the patients in that case, did they have to pay for it separately, or was it something that you covered from the hospital point of view yourself? It is a question from the panel.
Yeah, that's the question of reimbursement is a very hard question, of course. You know, we have to Peiper case. And in this Peiper case, there's all covered, which you have to use. And they say, okay, it's a mixed up calculation. And so if you do anything special, they won't pay that. But we are working on it. And we are just filling out forms to send it to the legal insurances. to get some more money, but it is hard business, let me say that. We have to go to the ENEC and try to get out a new pay per case for these patients. And we will get that by more scientific work and by more publication. And so we have in our pipeline, we have our RCT, which is ready to go right now. And after that, we have, I think, good results, which can compare component separation with the possible complications with the fascia traction method. And there we will find out that it might be better or might be less prone to higher cost. And if we got that, then we have a good argument to get some more money probably for this procedure, because we have to pay a little bit for the apparatus, for the technique, and this is not reimbursed in the paper case, in the Fallpauschale.
Another question from Endo Deba. Can you overpull on the fascia? Have you seen any tearing? Would Torgue methods make it more standardized?
Well, the rupture of the fascia was seen after the clamping, which Eucker did. So because he had no feeling and no control of the power, which he used to track on the fascia, and we have this control, and the clamps can damage the fascia more than a controlled inserted suture, because with a suture you have 2 points. When you lead a stitch and have a stitch length of 2 centimeters and stitch out again of the fascia, then you have 2 points where you can track, and you can put an average of the traction on the suture. While you have a very severe and a very narrow point in tractioning when you use the clamps, which Eucker had done. And so there I see a complete difference, that it's more complicated to use the clamps than to use the controlled stitch sutures, which we have. There's another advantage of the system.
Okay.
I would like to give another comment on this device. I think it's a very clever device, this ring, and it makes it very easy to get the sutures fixed in the right manner, with the right kilograms of and with the right force of traction, not overdoing and avoiding tears. And this device allows a very fast deployment of the sutures, insertion of the sutures, and if during the 30 minutes of traction the tension decreases, it's very easy to get the sutures on the right tension. So after 30 minutes, we end up and many times with closing the gap. Henning, what do you think?
How much time do you need? How long does it take to set it up from the point where you decide to use it? How much time does it take to set the thing up and have it running?
Well, that's very short. If you have a little routine, this is a 5-minute thing. This is not very long, and we can prepare all the things while we are performing the preparation of the fascias. We can already start to put things together. We have spring balance, and we have a special frame, and we have a carrier which holds our arm over the OR field, and where we can put all these things together. This is a stitch system. It's really easy. It's easily done. In the beginning, to start with, it might be complicated to get it in under sterile conditions on the OR table, but if you have a little bit exercise, then it takes you 2 minutes. This is not very long, 2-3 minutes, and then the time of waiting is starting. And you have to be a patient, the operating surgeon. This is hard, but I'm going out every time, drinking a little coffee, and then come back, because the assistant's doing the retensioning of the single sutures in the frame.
And to stay a bit in the subject of complications, did you have any cases of fascial necrosis due to the tension or to the intra-abdominal pressure?
Very good question.
How long do you measure the intra-abdominal pressure, and did you have any cases where you had to reduce it, like in the operation, to have the patient be more relaxed or have less fluid to have?
Also, we didn't have those problems with the pressure. We had no compartment, and we are just controlling one night in the intensive care, and when necessary, longer, of course. But in our cases, it was so that we didn't, that it was not necessary to perform a little longer control, because after day one, they could be discharged on the normal ward, and so then without tension measuring. But we are doing it for 24 hours, yes, the measuring of the tension. And second question, we didn't have any necrosis in the fascia, because we do not do a very broad preparation of the anterior sheet of the rectus layer, but only 2 to 3 centimeters from the edge, so that we can safely stitch our sutures in and out again, with a distance from the edge 1 to 2 centimeter and a stitch length of 1 to 2 centimeter as well. And by that, we avoid the complication with necrosis, infection, and so on, and less circulation. I think the reason for the necrosis is very often less circulation, which occurs when you perform a really big preparation, the skin and subcutaneous fat tissue from the fascia. And so avoiding that, you avoid the complication.
I would like to give another comment on using other devices. Of course, this is possible, but this device we have here with the fascia tense device we have been using, the advantage is that the sutures are in this oblique manner. They is in this oblique direction. This avoids component abdominal compartment syndrome for 30 minutes. If we do the traction like this, and we try to close the gap like this with the same force, then we create an abdominal compartment syndrome for 30 minutes. I don't know whether this has a clinical significance. Probably it could have. So I think it's very important to have a device with a traction of the sutures in this direction, in the oblique direction.
Diagonally.
Yeah.
Diagonally vertical. That's it. That's a combination which is very good. And this is in opposite to that what Eucker does. He does really vertical traction, so he has not the compartment syndrome.
You mean horizontal or vertical?
Vertical. This is what Eucker describes. He describes the vertical. And then what you meant is with the suturing against the Platzbauch in Germany, I don't know the word, breast abdomen, we have sutures against the breast abdomen, and that's what Wolfgang meant. This is a very hard and very pressureful method to get a closure of the abdominal wall, the inner abdominal wall. And so I think the best compromise between both is the diagonal vertical traction, diagonal vertical, as Wolfgang said. This is the best method, I think, and which is our experience after 50 cases now.
Henning?
We do have Eucker on the
9. That's great. Hello.
Panel. He listens, and he also has a remark about the use of the clamps that was mentioned previously in the Aufenberg procedure. That was not a problem. And the clamps did not cause the damage to the fascia as long as you do not pull extremely hard.
That's right.
Perhaps he can also, if he hears us, make a comment about the vertical or diagonal traction.
Yeah, of course.
That would be, of course, very, very helpful.
From Dietmar now, Dietmar Eucker, huh?
Yeah, exactly.
Great.
Yeah. He sends greetings from Basel.
Thank you.
Thank you. So, Henning, during the operation, you decide to use this device. How long to set up when you decided to use?
You mean the setup of the device? It's very short.
How long does it take to set up it?
2-3 minutes, no longer, because we can prepare it already when we are preparing, and we know very often very early that we should use it or not. And then I say, okay, pack it out, get it out of the package, and open up and prepare it just on the table, on the desk of the nurses.
Okay, and
Then it takes 3 to 4 minutes, not long.
It takes 30 minutes to implement and apply the procedure. During this time, someone is next to the patient and they make some adjustments or go to the drink coffee.
Well, I'm very often drinking coffee, but my assistants stay with the patient and do the retentioning and stay there and our observations. That's clear. And it's for me a little luxury. I get out and drink coffee.
So you can see Henning has a lot of routine. He goes having a coffee. I would never dare that.
I have a remark.
No, but I'm not very far away from that, and I can come back as soon as necessary. But I have 2 very well trained assistants helping me, and they know how it works.
Yes, we have the answer from Dietmar Eucker about the traction, and he says that his idea for the vertical traction was the better effect of tension direction on the lateral and dorsal abdominal muscles. So that was the idea on the vertical traction. Thank you very much for the comment.
Great, thank you so much, Dietmar.
And another question from the panel. I think we also discussed a bit if it's effective in acute case like burst abdomen following emergency surgery. Like I said, the initial use of or the conception of the fascia tense device was the treatment of an abdomen treatment that has shown also promising effects there in terms of fascial traction, and also that in the cases in the open abdomen, one positive, if you compare it to the standard MES deviated traction, that because of this diagonal traction of the fascia, that you avoid the compartment syndrome that perhaps you want to you make if you put a MES and you push it too far away. So we had some cases, for example, where we've put a MES to have an open abdomen treatment, and we had to open it in an emergency setting in the ICU because it was too tense to strap, and then with this device we didn't have any problems.
Great. So that's fantastic. That's our experience as well. We do not have experience with the open abdomen, but we only have experience with the hernias as remnant of the open abdomen. But others have very good results with the open abdomen as well. And I don't know whether Halil is in the chat.
He's in the chat. He's in the chat.
Probably he could say something for that. He's even the more.
When I was preparing this session, when I read the paper, and I was thinking about the working mechanism of the progressive traction. You know, we used to anal dilatation in treatment of the Alf fissure. We apply progressive tension to relax the muscle. Is it the same procedure that makes lateral three oblique muscles relax with progressive tension and makes things come together to the midline?
Yeah, I think this is a really correct thing and thought yet, which you have said just right. And I think this is the reason for stretching. We have seen this in the porcine model, that there is a good stretching of the lateral abdominal wall, that it is possible to stretch it. And probably it has some micro problems in the muscles and so on. But in the histology, which was taken after the porcine model, there was nothing found which led to the idea of damages of the muscle with micro fractures or things like that of the muscle fibers. This could not be seen, but so it must be the effect of stretching that you can gain the length of the fascias on both sides, yes, and you can do the closure of the midline. That's the pathophysiology, I presume. We don't know it exactly right now. We do need some more research, of course.
How long was your follow-up so far on the cases?
Yes, the follow-up of our cases is so far, it is not so very long. It's the longest is about 1 year right now. And we could see that we do not have any recurrent hernia. We had none of them. And we had sometimes, we had longer lasting pain in the edges of the mesh, which is very well known from other procedures as well. But specific procedure-related problems we didn't see. No compartment, no infections. And we had, from the beginning, we had 12 complications, and from which 6 had to be done operatively again with the VAC procedure and so on. And so we had 12%. No, it was 12%. Of complications, and we had 6% reoperation. So that was it. And this was directly after the operation while the hospital stay. And in one patient, we had to perform 11 times VAC procedure in one patient of 50, which is not so much, but this gained a good result after that as well. But it took a long time, of course.
Do you think it has more or less complications that component separation technique?
Less. And these are our results from our observational studies. It has less. We see in Ramirez, it is described about 48% of complications, and we had all complications together about 12%. And so we have different steps, of course. We have the TAR, which much less complications than the Ramirez, of course, and the endoscopic has less complication as the Ramirez. But one can imagine that all the invasive procedures, as the component separations are more prone to complication than the traction method, because we leave the compartments intact. And I think this is the advantage of that. And our results show that as well. And we can show that we do not have in between, in big meta-analysis, we can find out that for a different component separation are described complication rate between 25 to 48. And we are just starting with 12 and low and less. And
I would like to give a comment on the treatment of very, very large hernias, giant hernias, especially on the midline. I think it's very important, even in these big hernias. It's the mesh overlap. The mesh overlap is crucial. So I wouldn't recommend, even if you start with a reef stopper approach of the rectus compartment, retromuscular dissection to the lateral edge of the rectus compartment, and even if you achieve tension, the gap closure with low tension, sometimes you might end up with a situation where the mesh overlap is too small. And in this situation, I would strongly recommend to do the TAR procedure additionally, just in order to get a large, comfortable overlap of the mesh. So I think these techniques, the fascia tense and the TAR, they are very good in the giant hernias. They are very good together. Very good together.
I completely agree with you, Wolfgang. That's correct, because in the really loss of domain, the really big ones, it's really important to do the combination of both to have a good mesh layer. And so for that, for me, it's a little thing which I have to add, is that we leave the posterior sheets open. We do not force any closure of the posterior sheets of the rectus sheath, because we think that if you do that, you perform a compartment syndrome, and you can leave it broad, leave it the left posterior sheet of the rectus sheet, and leave the right one, and in between you need to close the peritoneal layer or leave the sac. This is of high importance. So leave the sac, not to cut it away.
Absolutely.
And if you leave it open in this way, it is not open, it's closed, but you have a closed space. If you have it in this broad manner, you can perform a really big mesh as well. But you're completely right. If you are considering the really big giant hernias, you do have to perform a combination, Botox, fascia TENS, and TAR, to gain much space for the mesh.
There's another interesting question here in the chat. I can see it. It's a question about the treatment of a 12-year-old girl. Henning, what is your opinion?
A 12-year-old, I didn't understand it correctly. He has a large hernia.
It's a 12-year-old girl with incisional hernia after medial laparotomy.
Yeah.
Large incisional hernia because of peritonitis by perforated appendicitis. I will use fascia TENS to avoid mesh implantation. Do you think it's a good idea? I think it is, of course.
If you can gain a closure without mesh insertion, you can do it. But my primary technique or my primary thought is always to perform a mesh inside.
Oh, but this is 12-year-old girl.
12-year-old girl. One can consider, of course, do the fascia traction and do it without closure. The first technical procedures for to get attention and to get the compartment for component separation were made without any mesh insertion and were done for the complete closure with only natural material. And so for a 12 years old girl, probably one can avoid the mesh. Yes, probably when necessary.
That's what I would try exactly this.
Yeah,
I would try to do the fascia TENS maneuver. If it doesn't work, I would go on with a retromuscular dissection in the rectus compartment without mesh, because if you open the posterior rectus sheath and do the dissection between the posterior rectus sheath and the rectus muscle, this gives you a good release on every side. We know it from the original papers by Oscar Ramirez that the dissection of the rectus compartment without mesh, even without mesh, just mobilizing the posterior rectus sheath from the muscle gives a good release. So I think my option in this 12-year-old girl would be open it with an incision only the length of the defect diameter. Apply the fascia TENS in the mini or less open approach, and then try to close the gap.
And with natural material, without any mesh.
And if it's still not possible to close the gap, then in the 12-year-old girl, it's probably it would be. I would use a long-term absorbable mesh.
A long-term absorbable, yes, that's it. What we can do then, yeah.
Speaking about the concept of AIDS, have you noticed any difference in the width you are gaining in more younger patients or older patients? Are younger patients that perhaps have more elasticity in their tissue? But are they more? Do you gain more?
No, not always, because younger people can have very strong muscles, and so the elasticity of the abdominal wall is not so big as in the middle age, a little bit fatty male, which is very often the best one to do operations on, because then the muscles and the fascias are very elastic and you can pull them together very easily. But in the strong, very well trained younger people, this might be very hard. This is my opinion and my experience. Not in everybody, but in some. And if we will make a difference, and if we're considering younger people to be done very easily, this is not correct. It is more easy to do the mid-age, a little bit fatty males.
So it's like the opposite. Younger, it's harder, but middle age are easier, and then probably the older you get, then it's also again a bit harder. It's like a bell.
Yeah, that might be because of it is tracked together, and you have the icing of the muscles and abdominal wall freezed.
Okay. Yeah, we have come to end of this month's Journal Club session. And I'd like to thank you very much, Henning. Thank you very much, Wolfgang, for your joining in this hot summer night. And also
Thank you for organizing.
Great contribution. Thank you.
Thank you very much, and it was a great honor to be part.
Hope to meet you all the next Journal Club session. Have a nice evening, all.
Have a nice evening.
Bye-bye.
Thanks from everywhere. Thank you very much. It was a great honor.
Hakan, thank you for organizing this.
Very good.
Alexios, thank you very much.
Wonderful.
Thank you very much for the discussion.
It's a really big thing. Okay, I'll leave you. Bye-bye.
Bye-bye.
Bye.
Alex, it was great. Thank you.
Bye-bye.